Welcome to our little discussion around diagnostics and climate change. Should we start off about, do you want me to kick off?
Please go ahead.
Okay. So I've got a bit of a soapbox when it comes to climate change. So I'm going to start off by saying we keep saying climate change. It's not really climate change. It's a climate crisis, which in turn is a health crisis. And it was really interesting to hear the previous conversation going on about the interaction with the US government and how they're thinking about funding. And one of the questions I should have asked was really, is it possible to put the funding under a main silo, and that silo being global health security? Because then global health security tends to capture a lot of things that we're interested in, and then hopefully that's something that will keep people interested in that space. Anyway, this is not about me. I'm going to
comment on the previous panel.
That was a comment on the previous panel, and then a sort of a bit of introduction as to where we're going to go and where we're going to plant our tent in this space. So Joël, if I'm going to hand over to you, because otherwise I'm just going to keep talking.
No,
so.
that's true. That's a duo, and I guess the exercise. We also look forward to your participation. I guess climate change is probably on the mind of everybody here. It has become the talk of the town. I've been going around town, which is normally World Health Assembly, has focused on health, but actually every second meeting is about, indeed, as you said, the climate crisis is a health crisis. It wouldn't be surprising for those of you who have been working in remote communities on the tropics, where you have seen already the impact of climate change. In fact, the brunt of climate change has hit mostly a low and middle income country belt. And it's very interesting because much of the crisis that we have seen until now, especially I would say for infectious diseases, actually it's kind of the same story again. In other words, we're discovering climate change in the north. We're discovering suddenly dengue bugs, or at least the tiger mosquito even in Geneva. We are seeing kind of all kinds of news, but that reality has already sunk in recent years in quite a few countries that have been affected not only by climate, but change in terms of change of rainfalls and change of temperatures, but actually also climate-related migration, which this house is also very sensitive to. And so the both are, and we can discuss that, both are actually part of this equation in terms of affecting health and the prospects for our collective. So what I was trying to say, it's almost a new take on an old issue, which is there is no innovation for the neglected patients of diseases that are mostly priority diseases of the global south. There are lots of other kind of very similar conversations, but it's now under a concept that a lot of diseases are climate sensitive, and that migration is fueling the spread of infections. Maybe that's it.
I attended a session this morning on arboviruses, and that was one of the main things that came out about it, was talking about the fact that there are a lot of different drivers. So, you know, when we talk about the climate crisis, there are significant complexities around it. So for some diseases, we can predict that's going to be the case. So for malaria, the WHO World Malaria Report talked about the likelihood and talked about how there's some evidence, but there's significant gaps in terms of what we know to be able to support treatment of disease. Whereas if you look in the dengue field, there's so much more data there. You can tell straight away that there is an explosion in terms of South America, into part of the southern United States. You mentioned Europe, so we're already in Europe. I was at all-party parliamentary group meeting last year where the British government was talking about dengue coming to the British islands. So you're right. It started off as an issue. It's been a problem for a very long time. You know, when we talk about dengue, for instance, to stick on that topic, in Africa, we've known about dengue infections in Africa since the 60s, if not earlier. But it's only now become a problem because it's beginning to spread so rapidly everywhere. There's now huge numbers of people being infected and large number of deaths occurring in Africa. Burkina had a massive problem last year and was unprepared for the impact that was going to bring. So when we talk about how climate is affecting or climate might be impacting on disease progression, and really down to diagnostics. We're really thinking about, we're not ahead of the curve. We're definitely behind the curve in terms of how we get on top of that particular problem.
In fact, I think this week the WHO released a publication calling for scaled-up surveillance of malaria and NTDs because of their nature of being climate sensitive, and acknowledge that the data is scarce. Yeah. And it's very uneven. It's very uneven among the disease, as you mentioned. But I think I would tend to agree with you that dengue is like the poster child. Okay, so we didn't really have the tiger mosquito in Europe 30 years ago. Everybody now is, realizing that the incidence of disease has in the last 2 decades has actually increased tenfold worldwide. So that at least the aggregate data shows that it's considered that about half of the world population is at risk of dengue now. And yet, was this a word in our vocabulary, 5 years ago? Not quite. So it's becoming, however, it was for decades the preoccupation of Southeast Asia. It has been killing in Southeast Asia for decades, but we ignored. It was a neglected disease. It ended up being lumped into a number of other diseases, in fact 20 of them, called neglected tropical disease, and kind of discounted. Not much money went there, not much research went there, and now we're kind of seeing the scenario happen where it's taking off. It's present in most continents now, and the epidemiology is fastly evolving. So dengue is the poster child of that, but interestingly, you refer to data and the availability of evidence. I think that even in Africa, if you ask ministries of health in general, what is their level of dengue infections, most of them are not able to tell you. Before COVID, or just during COVID, we actually realized we had a unique opportunity because there were blood banks developed everywhere where we could actually do serological tests for the presence of other diseases. And we discussed with our colleagues in Ghana whether there were any dengue in Ghana, and they said no, elsewhere but not in Ghana. And we did the serological test and showed that in the places where we did it, so that doesn't mean that it's the national epidemiology, but where the test that we used showed 40% presence of the clearly, what we have here is a completely underdocumented reality. So diagnostic is the key word here in its broader definition, which is surveillance, which is understanding the presence of the pathogens, and all the more important because when you have should come back to what are the dynamics of climate change onto the diseases, but we are going to see more and more effect, and it's not just a real linear point. But let's come back to that.
No, I mean you're absolutely right. We've not really, we've known about it for a long time, but we've not really prepared ourselves for this. And on that point about the climate and the impact on health and on the diagnostics, we're in a position now where we're risking driving AMR with climate change, because climate change is impacting across the entire portfolio of diseases, of infectious diseases, and it also impacts on non-communicable diseases. So what it means is that you're in a situation where there's a huge demand, there's an increased demand for what we need to do and what we need to deliver in terms of those diagnostics. And under my program, which is malaria and fever, we've got this issue where we're thinking about, we want differential diagnosis. We want to be able to tell whether the fever is malaria or whether the fever is a viral pathogen. Now, if the health practitioner doesn't know, they're going to go with they're going to go with an anti-malarial, and they're going to go with an antibiotic. And we know that because we've talked to people, and they're telling us that this is the case. I knew that from my past life when I was an academic, and we hear that now from the clinics. So, as we're talking now about the impact of climate and health, it really is quite a broad, it's touching on pandemic threats, which was before, it's touching on NCDs, it's touching on women's health, it's touching on across the entire aspects that we look at FIND. So, we're working quite hard to try and make sure that we're trying to address these gaps in the portfolio to make sure we can try and address that. I was talking to one of my colleagues earlier on about the women's health part, and you've got women's health in terms of, you know, non-communicable diseases, but you've also got women's health in terms of communicable diseases. There's an increase in terms of malaria, increase in terms of dengue, both of which have an impact in terms of pregnancy-associated impacts. So, you know, we're looking at a situation where, in the previous session this morning, Francis Kwan was saying that he feels quite scared. You know, he organizes the Asia Malaria Conference, and he said he's quite terrified now when he looks at the situation with some of these diseases, not just dengue, when you look at these other aspects, because it complicates the story. It really complicates the story and makes things very difficult. So, you know, Jolie was talking about innovation, and we're going to come back to innovation, because that is going to be a critical point to how we take this forward. Because without innovation, both in terms of surveillance, but also in terms of diagnostics, we're going to struggle. So.
Before we go to innovation, maybe understanding in the category of infectious disease as opposed to the broader health impact that you identified as linked to climate change. There is really a series of, I mean, it may be worth it to explain why we're having more infectious disease. It doesn't seem to be obvious, right? You can understand that the heat may make your heart or your, you know, cardiovascular health affected, or at least lung health as well. With but why infectious disease? So, climate change actually raises the temperature, or let's say changes the temperature, raises eventually the occurrence of rainfall or drought, and by doing so, it has a direct and indirect consequence on health. The direct consequence is that it has an impact on the vector, meaning diseases are communicated either directly or actually through a vector. A vector can be a mosquito, a fly, or any other living organism that is actually carrying the disease, not affected, but carrying it. So most neglected tropical diseases, including dengue, and of course malaria, are actually vector-borne diseases. Some of them are waterborne diseases, and both vector-borne and waterborne are, of course, affected by the climate change. The climate changes the ecology of the vector. The mosquito are now going up in the mountains because it's getting warmer up there. So you see in East Africa, for example, diseases that may not be in the highlands are now moving into the highlands. So this is the first effect, which I would call direct. The indirect effect is that infectious disease being carried by humans, the migration of humans is also carrying the disease. And when you have a convergence of vector and humans migration, you have eventually a real exposure, which is exactly what we saw with dengue. So those two factors are playing into the risk. It's unclear. And I think we want to be very, we're influenced by scientists behind us. We want to be very clear that nothing is, like the IPCC showed, nothing, we really need to rely on the scientists, and nothing is linear. We have no guarantee that for any disease it will be going up everywhere or down everywhere. In fact, most cases, it might simply be a matter of changing geography for the disease. But when you change geography, you have another problem, which is the fact that you suddenly find non-immune population. The disease may also, because of the different environments, show itself differently. So what you're being used to diagnose dengue fever in one way or sleeping sickness in one way, but actually suddenly the ganglions don't show anymore the same way and you don't detect it as well. So the practice of diagnostics become even more reliant on having the right tools and the right capacity to respond. So I thought it was important to kind of connect why infectious disease are, in fact, climate change related.
Absolutely. And I'll take on from that point. And when you were talking about droughts and floods, we were talking about this in the session earlier on about how albopictus is a particularly troubling vector species because actually it's happy in the floods and it's happy in the droughts. So what's happening is we're seeing extended seasonality. So the panel included a minister for health, and he was talking about how he spent some time in La Réunion. You can tell my French is great. When he was younger, and how it was very seasonal. So he had seasonal transmission, and then during, during the dry season, you didn't. But he said now what you have is all year-round transmission, and we are seeing that increasingly in lots more places. Now, the issue for diagnostics is, if we think back to what happened during COVID and the massive demand for diagnostic tests, we're now operating in an area which was, as Jolie said, was largely neglected. Now we're moving into a phase where there's a huge demand for diagnostics. There's already stockouts happening. The minister for Brazil was saying that because of the situation they've had there, they bought out a load of diagnostics, and they think they bought all the existing stock of diagnostics. So that's, that's already a stress on the health systems in terms of, available reagents and available materials that you would need. Yeah, I think I'll pause there.
But it may be, we're painting a rather dire picture. So sometimes it's good also to start looking, okay, how do we get out of that pickle? It's true that the clock is ticking, and in the case of neglected tropical diseases, for example, the progress of recent years most have been very significant. We're talking about elimination of sleeping sickness. We are looking at the possible elimination of leishmaniasis. This is quite significant. It's the elusive elimination, maybe because climate change is coming and might reverse the trend. So on the other hand, I think that there may be some interesting conversations happening around here, maybe uphill on the other side at WHO or down at the Palais, which are happening this week, that have the promising elements. So the first is wanting to understand better the world we work in and willing to put some funding into surveillance and understanding. If you do funding on surveillance, in order to survey, you have to go and meet the people. That means you have to go into the affected communities, which are usually not even diagnosed or treated. So it will inevitably have an effect in the end of putting the limelight and the resources where that matters, which is in the most affected communities, where the infections are most important. The other element that is being discussed, as you all may be aware, is the treaty, or at least the how do we actually respond to a pandemic. At the heart of the treaty, even though the focus is on pandemic and health security, in truth, there's also sub-conversations about how do we create healthy ecosystems for manufacturing of health products in regions, with the kind of problem that Brazil has faced with dengue this year. The strength of Fiocruz in the National Agency of Public Health, which also oversees public manufacturing of health goods, has been a godsend. If you had actually only a dependency on only private actors, you would not have had the same forceful response. So there is, I would say, a transformation in the making. Difficult one. We probably will hear tonight that the treaty discussions are further postponed before we can get to a positive outcome. But there are at the heart of this discussion really conversations that are pregnant with potential for responding to this climate crisis.
Yeah, and I guess I can take us back to COP28, and apart from the fact that there was a historic event that we had the first health day, there was a lot of discussion about partnerships, and we haven't had a chance to talk about partnerships here, but that's essential. Partnerships in the country, partnerships with the funders, partnerships between organizations, those are critical to going forward. And in the previous session, Stephanie was talking about how there's a finite amount of money, and we've got to think about ways and how we can access those funds. At COP, there was a lot of discussion around value added. So there's a lot of discussion about how we can go in and try and tackle multiple things with one pot of fund, get more for less. But there are ways you can think about that. If we're thinking about dengue or other arboviral infections, or we're thinking about malaria, there are ways you can try and think about how you might be able to piggyback onto existing studies, how you can get more value from that. So you're studying dengue in one region, then maybe we can also be looking at malaria or Zika in that same area. The Wellcome Trust has got an RFP out at the moment, closing soon, looking at dengue and Zika. Now, the reason for that is there is very little information about what happens when you have co-infections with those diseases. So we want to talk a lot more about diagnostics. We want to talk about, when we want to talk about diagnostics, we really have to think about how those diagnostics are going to perform in a region where there's more than one infection. So when we start to think about, you know, what's value added, trying to think about that space, how we think about how we can look at multiple infections in that space, then we start to think about global health security, because we're thinking about how looking at all those different things together allows you to think about global health security in that way. We were in the States a few weeks ago where we were talking to a number of different government bodies, and actually one of the conversations, in fact we were talking to OPPR, and one of the conversations that came up was around global health security, because you know, the US is at the forefront. You've got Brazil having a runaway infection with dengue. Brazil's doing an amazing job to contain it, but that's still leading to a lot of infectious cases. Those cases are at risk of crossing the border, and once they get into the border, you can already see from the maps that the southern United States are already, have dengue infection. They're already at risk for it. They have the environment to support it. So the concern from talking to these partners is that, you know, once it gets established in the country, then you're in trouble. So I guess the reason I'm kind of moving, you know, from LMICs into the geographical north is I'm trying to bring the point that, you know, when we're thinking about diagnostics in this space, we really should be thinking about it that this is a global threat. This is no longer a threat in LMICs. This is a huge problem that we need to deal with. We need to help our partners deal with before it becomes a problem elsewhere. Because once it becomes a problem elsewhere, then we're having the issue of competing for resources. And I think that is something we don't want to avoid. We had it in COVID, wasn't nice. It'll be good to avoid it this time around.
Well, yes, I agree. And of course, in Europe, everybody, there was even the creation of HERA, an agency of the European Commission. It aimed at tackling the issue of global health security in after COVID, but also in view of the fact that, for example, dengue, they are now locally acquired cases in France, in Italy, and in Spain. So we've been immune in Switzerland. You probably won't get it by attending this conference, but clearly this is kind of a few years away. But I get really frustrated when when I feel even worse, when I feel complicit sometimes, when I have to use the argument of the high-income countries now being threatened by these diseases, and yet the fact that these diseases have been present and killing and creating cycles of poverty in a lot of countries already. The United States, to be honest, I'm not sure if anybody representing the US here, has actually a disease called Chagas disease on its territory, and has a very large number of Latin American population has migrated to the United States, carries the disease. It's a hidden disease. It hides in your body for decades, and then at age 40 maybe, or many decades later, you have heart problems and you need a heart transplant. Your heart transplant will eventually cost $100,000, and you probably can't afford it because of the health system in the United States. Why are we not looking already at this health equity issue? Sorry, I also have a U.S. passport, so I can criticize my own country, and I consider that this is very uncomfortable. So I do go to Washington and I say, why do you not invest a single penny in innovation for neglected tropical disease when you have one already in your own country, and yet US is one of the top donors of global health? I think we need to really start make this case, but with keeping in mind the notion of health equity. And I was at another meeting this week about the idea of financing health differently, global health differently, recognizing that there's less and less fiscal space in government, like everybody's trying to pack a reconstruction budget for Ukraine inside the aid budget and inside the foreign aid budget, which is squeezing for more and more money. The climate mitigation agenda is looming large, and the climate adaptation is much larger than health. This brings a lot of preoccupation for the public funding. So a lot of people are saying, okay, can't we mobilize a lot more of private funding, including impact investments? We have these bloated financial assets that potentially could contribute. And but then the question is, will they invest in equitable access? Will they invest in the technologies that make no return, that are not affordable to the least empowered patients? And I think we need to construct the future of global health to be global and not driven by northern interest again.
I agree. I guess one of the things I'd like to do is really change the narrative that, the diseases, I think it is important that we understand where the highest burden those diseases are. But it's also worth noting that we have an opportunity to look at a two-way dialogue rather than a one-way dialogue where we're expecting funding to come from one way to go towards solving a problem elsewhere. I think that two-way dialogue is important because there's a lot the geographical north can learn from the geographical south and vice versa. And I think it's really good to keep that narrative going because, when I talked about partnerships and talking with in-country partners, fine, that's what we do. We want to go and talk to country partners to understand what the needs are and know how best to help support addressing those needs. Now, in doing that, we understand better what is needed rather than sitting my study in London or in Geneva to try and think, right, we think they need this. And I think that always misses the main issue. Understanding what the country needs are is going to help us really align and build better diagnostics to be able to fit in that space. And I guess one of the things I wanted to move us on to was when we talk about the structure and what happens with climate and health and how it's expanding the risk, changing seasonality and regions of risk. The other thing I'd like to bring us back to is what happens on the diagnostics themselves. So when we do have those tools, and we do bring those tools to bear, is that me? And we do bring those tools to bear, what happens to those tests? And we know, we and others have done work to show that temperature adversely affects the test. So we get an IFU, we work with partners, we understand what the temperature range is, and that temperature is maybe from 10 degrees to 35. But actually, for most of the countries that we're putting those tests into, the temperature isn't 35. It's going to be 40, 45, 50. And that really changes the impact on the diagnostic. It changes what we've been able to evaluate. So we do these very detailed evaluations to understand how they work. But once you put them in country, we then have to think about it. Think about what innovations do we need to be able to mitigate against that. And you had touched on innovation earlier on, and I think it would be really good for us to delve into the innovation, both in terms of the diagnostics and in terms of the surveillance that we will need to try and mitigate, and also understand potential adaptation strategies that require to be able to handle what's coming in terms of...
Maybe we should explain to our audience here that there's a reason why we're here together. I represent the Drugs for Neglected Disease Initiative, which develops drugs for mostly neglected patients. Some of it is actually neglected tropical diseases. And you represent an organization that develops diagnostics that are not necessarily adopted for initially by, the agenda is not adopted by the private sector, either for the drugs or the diagnostics, because it's not necessarily seen as profitable. So we create a non-profit dynamic that eventually keeps the industry in, but they eventually also lean on the expertise of the countries we're targeting, because we need both to succeed. And I'm not so sure why I got there. You were asking a question. Innovation.
I should also add that we've had, DNDi and FIND have had a long-standing relationship. So, in terms of why we're here just chatting away to you, we've also had this long-standing relationship. So there's a real natural partnership in terms of FIND working with DNDi and be able to take that
in fact, we developed treatments and diagnostics together. They are, of course, very parallel developments. They are anchored and informed by the very same communities. You need to go, we call it like the last mile, or some people say the end of the road. Sometimes it's the end of the walking trail. You have to even walk in water or on train tracks to get to the community. It's really very often very remote and very impoverished communities. It's the same that are informing the development of your diagnostics and the development of our drug. And at some point we were even able to make the concurrent testing of the diagnostic and the drug together. So that has been a really example of collaboration in order to do so. But I think we'll need to do more on that. But when we think of diagnostic, you can't think of, okay, I'm going to tell you what is your disease, but I won't be able to treat you. Then nobody will ever provide, no doctor will ever use a diagnostic only for the sake of identifying what the person's disease is. They will be necessary a pool to have a treatment, and they and I would like to step back. We talked earlier about the WHO calling for more intelligence on how much of these threats are around us in every country. How should they be or not a priority of the Ministry of Health? In order to do surveillance of diseases, you have to test. But if you test, you have to treat. So it's a vicious circle that we're in that actually forces that even though we could be friendly, we have to be friendly, and we have to really kind of work in sync to deliver the missing technology.
I agree. So that this is a subject that's come up in a number of the different sessions I've been involved in. The idea about how we create, how do we create these partnerships, and how we can think about leveraging funds by thinking about, and I touched on this a little bit earlier on about how we might get value added, but actually, exactly as Jolie mentioned, being able to think about, right, we're tackling something similar, so why don't we go in and think about how we can increase the impact by understanding what that nature of disease is and understanding how we can treat it. You know, diagnostics are the first step that you take in the patient journey. So it's incredibly important that we understand how that interacts with the treatment protocols that we have coming down the line. We're often forgotten when people talk about drugs and vaccines, but without the diagnostics, we risk, I'm going to talk about AMR again, we risk driving AMR because we don't understand what we're treating. We don't understand how we can engage in that space. So when we're talking about innovation, we talked earlier on about surveillance. So I'd like to come back to that point about surveillance, because actually, you know, diagnostics have a lot of role to play in terms of surveillance, that early warning system, that understanding of what's coming down the pipe. But also at FIND, what we're trying to do is really try and understand innovative ways that we can engage with surveillance. For example, reusing RDTs as a source of material with which we can look at tracking malaria resistance markers, potentially even expanding it as something that could be used to track other infections along the way. And so that will allow you this sort of early warning system, agnostic of the people, but you get a huge amount to be reuse these tests, to be able, these tools, to be able to make a step to the next point. Before we go on to diagnostics, I'll head back to you.
No, I meant, should we ask our audience?
Yeah, I'm enjoying talking so much. I don't really want to. I don't really want to include you guys, but I can see a hand going up. So Claire.
I didn't get my question in last time, so I thought I was like. I'd love to hear a little bit about technology, the technologies, the diagnostics, the treatments, the vaccines, and their impact on climate. So, you know, I know this is sort of something that we're just starting to really think about, like green technologies. So I'd love to hear some of your thoughts on that.
Allow me a slight detour, but it's interesting, I think. A couple of years ago, when we decided that we wanted to look at this issue of climate and innovation, we had a board meeting, which I prepared to say, where do we want to put the cursor on? Here we are developing drugs for, you know, specific neglected diseases. Do we want to just simply move a little bit? And I would argue to you that a little bit requires already a lot of work, which is to become at least looking at our carbon footprint, looking at green technologies with regards to drug development and so on. And what does that mean? Do we want to go further? And how far do we want to go further? For example, do we want to become specialist of innovation for treatments, therapeutic innovation in the context of climate change? And our board decided in the end that the drugs for neglected diseases needed to be broader than climate change. It's not only climate change that is driving neglect. So we would stay focused on the neglect, but we would bring the cursor out. And what was very interesting is that the statement, this was 2020, I think, the statement was, or 2019, the statement was, we cannot be an institution of the 21st century without looking at our carbon footprint. And as a drug development organization, we cannot be a progressive drug development organization without looking at how the drugs are being made. So we did a journey. First, we took stock of what are we doing that's good in this area. We realized that we were getting the world rid of really toxic drugs. The drug we used to treat sleeping sickness in the 90s, and I was in Uganda at the time with a major epidemic there, killed 1 out of 12 people. The drug itself, the disease killed 100% if not treated, but the drug itself, it's so toxic, it was an arsenic derivative. Do you imagine the production effect, environmental protection effect of producing something like that? Instead, we've introduced new drugs that are much better and do not have the same effects. We're also looking at kind of production process and engaging a dialogue with pharmaceutical companies on how we can improve this. The other thing that we've done is actually look at our carbon footprint and say, okay, we have to really cut it in half too, like all of us. I guess all of you too, maybe some of you, if you are Geneva-based, cycle to work, whereas years ago you would have driven there. I think that we're all doing this, and as an institution we did that. So couple of months ago we announced our pathway. By the way, I make an announcement here. There's an agency in town called the Climate Action Accelerator, whose main objective is to help organizations do this journey and really identify the pathway for them to reduce their emissions. And it collaborates with all kinds of NGOs. It worked with the Red Cross and Red Crescent movement and Médecins Sans Frontières and other humanitarian organizations initially, and then it went to health agencies, and it's probably for all of your agencies maybe a good partner for that. But that's, I think, a way to answer your question, maybe?
I guess from my side, what I can say is the diagnostic area doesn't have quite it's not the largest footprint in terms of healthcare. That really is elsewhere. But what we try and do is we keep an eye on green technology. And we have to have this balance between moving to green technology and delivering the RDTs at the price point that we need to be able to make it accessible to all. So at the moment, what we're doing is we keep an eye on it, but the technology isn't yet where it needs to be for us to be able to move, for example, RDT productions into that space. One of the other things we're doing is trying to look at technologies that don't have as much in the way of consumables. So non-invasive technologies that allow you to be able to get an assessment of infection without requiring consumables, but has one device that does that read and be able to engage. And so those devices, which we're working on at FIND, those devices allow you to be able to address diseases in a way that we cannot conventionally do with RDTs. So for example, with RDTs, you come in, it's a symptomatic test. So you come in with symptoms, you get tested to see what you have. But with some of these other tests, the potential for them is you can actually address things like asymptomatic carriage for malaria, which should be a game changer when we start thinking about elimination narratives. But also these devices also have extra utility about being able to look at other infections, potentially even viral infections. And you can imagine what kind of impact that will have. So in terms of how we address climate change and things like that, we are constantly trying to be innovative in this space. We're constantly trying to think about new ways about how we bring diagnosis or diagnostics to bear. So to Jolie's point that you cannot be a forward-thinking organization without thinking about the impact that you leave, the footprint that you have, we try and do that. We've already cut our travel quite significantly. And by looking at these sort of technologies which allow you to be able to engage in this space, then I think we're doing what we can at the moment, but there is still more that we can do.
We were chatting earlier, and because you tell us you got us to say the how do you say virtuous ways that we're going, right? But let me share the difficulties of traveling that path. So there is this incredible movement, our organization, everybody's so mobilized, they're all proud to be part of it because we're doing this. And at the same time, there is this discussion about drug discovery and how the new technology is allowing you to do drug discovery virtually through artificial intelligence. It's amazing, because drug discovery initially, where you had to go through the testing biologically all the compounds in every single library on the world, whatever, with a real, biological way. Now what you have is the ability to deconstruct and reconstruct with artificial intelligence, identify the kind of protein that would make sense or whatever. But then I heard recently, I was at a conference, that artificial intelligence now is using is having as much carbon emission as the country of the Netherlands. So that means an industry in itself is actually becoming as large a player, and of course that's today. Probably tomorrow will be larger than the Netherlands, and at some point it will be larger than any country. And I think it's these trade-offs are tremendous, because you cannot deny the possibility of accelerating, especially with the clock ticking on climate change, accelerating the development of new drugs for neglected patients affected by climate-sensitive diseases. But on the other hand, if you want to do it fast, you have to use tools that are, again, energy, and it's massive trade-offs.
Yeah, absolutely. And so that's another balancing act, right? So okay.
Either take the last question or wrap it up.
I'll take another question. Is there another question coming? So I'm just going to say that's a balancing act, because it's a very powerful tool to allow us to move forward, but we've got to think very carefully about some of the technology that we need to do that reduces the energy drain and draw that AI has. We can't say no to it. We just have to think of ways to mitigate. Was there a question? You have to ask a question now, because I stopped talking.
Do you want to just give us some final thoughts, Kevin, and take us to the coffee break?
Right, so I guess final thoughts are climate change is basically or climate crisis is an umbrella which we and many organizations are looking at. We cannot avoid it. It's here. We have to think about what steps we can take forward to help health systems. We have to think about the mitigation strategies. We have to think of the adaptation strategies. Stephanie had said in the previous one, we can't just make the tools and then drop it in and say, you're welcome. We have to think about ways in which we can engage with countries, engage with the healthcare across the full spectrum from PHCs upwards or across, so that we can be able to deliver these tools, and these tools are really able to be able to do the job they need. And the last point is just to say that when we think about diagnostics and we think about diseases, we really are thinking about from non-communicable right across to communicable diseases. And that intersection, as we delve more and more into this, and as our tools get much more sophisticated, we might be able to look into a lot more into how these different diseases interact with each other and how they might impact and how we can help move things forward. I think that will do.